Hi, my name is Patsy Stutes. I am a family nurse practitioner student through Bluefield College. My full-time job is as a flight nurse for HealthNet Aeromedical Services. Just a quick rundown on my background. I've been flying for almost 4 years now. This summer will be my anniversary, and I have been in the full-time position for almost 2. The patients that we serve primarily are in rural parts of southern West Virginia, for me specifically. As a system, we service all of West Virginia and parts of Kentucky and Ohio as well. Our patient population is very ill as a general rule, and we are capable to transport patients not only from a pre-hospital setting, having never seen a provider, but also in the interfacility realm, with a lot of our hospitals being smaller facilities and considered to be critical access. When I say critical access, I mean that they are small facilities with very limited resources and very limited bed capacity. So for my project, I chose to use a project that is going to service my patients in a healthcare information realm. So I chose to do blood analysis systems. With the purpose being, our patients are super sick and oftentimes have been in a facility for an extended amount of time, or even having never been seen by a provider pre-hospital. A blood analysis system is going to be beneficial for these patients because it'll give us a real-time lab value reading. Because sometimes in making patient contact, even in an interfacility setting, their labs are often hours old and they are no longer pertinent to their current state. So obviously my compelling factor primarily is going to be patient care, because ultimately as a provider we want to do what's appropriate and best for the patient at all times. So these patients, as I said, have been oftentimes in a facility for an extended amount of time with old lab work. So to do the lab work at bedside is going to be beneficial because we can tailor our treatment to the patient's current state. This being said, when the lab work comes back, we can adjust our treatment beyond just that of what we're doing currently. What we do right now is we base our treatment on the patient's current presentation as well as anything the facility has done. So for example, if we do have a patient that's been intubated and does have an ABG, that ABG could be 6 hours old and we can no longer tailor our vent settings to that specific ABG. So blood analysis systems, depending on which system we would choose, there's 2 that we're looking at currently, which is EPOC and iStat. Both have their perks, both have their drawbacks, but essentially they both have the same capability. We could do arterial blood gases, we could do metabolic panels, and we can do complete blood counts. Of the 3 types of labs that we would do, an arterial blood gas obviously is going to be pertinent to adjust things like their vent settings. And in doing the research for this project, I found that there isn't really very much data about aeromedical transport as a whole. Anything that is done in regard to lab work or even patient care as a whole is primarily focused in the military. But the research that I'm finding from the military honestly is very similar to what we transport now. Mostly patients are trauma patients, they're going to be cardiac patients, and they're patients having neurologic emergencies. And then it kind of corresponded realistically as far as intubated and ventilated patients. 30% of our patient population, based off of our data that we pulled from 2018, are intubated and ventilated patients. And then again, it just correlates with the research that's saying they are primarily cardiac, neurologic, and trauma patients. Arterial blood gases are going to be pertinent to the ventilated patients because we can adjust our vent settings based on what their arterial pH, CO2, bicarb, all of that stuff comes back at. As far as the metabolic panel, this is going to be more pertinent to our patients that are, let's say, in DKA. Which honestly is a very frequent transport for us as well. So these patients are in a metabolic crisis, and we can tailor our treatment to what their glucose is coming back at and what like for example, their potassium comes back at. These patients are, it's very difficult to tailor treatment to these patients because most glucometer readings will only read up to like 450 or 500. So anything higher than that, you're going to get a high reading on your glucometer. So if we had a system that could give us a real number, we can tailor their insulin drip as well as their probable potassium drip that they're likely going to be on to the patient-specific population. And then as far as the blood count, this is going to be more pertinent to trauma patients. As a transport agency, we do carry blood products. We carry never frozen plasma as well as O negative, 2 units of O negative blood product. And honestly, at this point, we base our treatment off of the patient presentation. So obviously, if you have a pale, tachycardic, diaphoretic, hypotensive patient that has known blunt trauma to their abdomen, we're going to give that patient blood products. However, there have been instances in patients that we've transported that don't have that textbook classic presentation that would have benefited from blood products, because when we get to the facility, we find out after the fact that they have a hemoglobin of 5. So that's why this blood analysis system is going to be beneficial to my patients. So as far as the process in initiating the blood system, it actually was a lot more difficult than I anticipated. So the steps included the West Virginia Laboratory Office, my education director, my medical director, one of the facilities that we service, and then of course our financial officer, vice president, and CEO. So I was able to contact the CLIA office or the laboratory office without any difficulty at all, and they were able to give me some direction. And then I took that information to my education director as well as my base lead, who both were super supportive of the project as a whole and gave me direction as well. And then we took that to the medical director, and that's kind of where we're at a standstill. So in order for us to do blood analysis in the field or in the inter-hospital setting, we have to have what's called a CLIA licensure. And this is an amendment in place by the laboratory offices and Medicare, Medicaid. And its purpose is to provide patients with accurate information. It essentially states that laboratory services that are provided to a patient have to be regulated and monitored to make sure that all lab work comes back to be accurate. There's a lot of red tape in obtaining that licensure. You have to have a lab technician, you have to have a medical director that's a pathologist, among other things, which realistically wouldn't be feasible for us. I actually talked to some colleagues at a critical care conference that actually do already carry a blood analysis system, and they said what was easiest for them was to piggyback onto their sister or owner hospitals that already had a CLIA licensure, because in their laboratory office they obviously have a pathologist and the technician that's going to monitor the equipment. We are lucky in that we are owned by 3 of the major medical institutions in the state of West Virginia. We're owned through Cabell Huntington, WVU, West Virginia University, and CAMC, Charleston Area Medical Center. Conveniently enough, my specific base is affiliated primarily with CAMC, who already has an ISTAT program in place for their NICU-PICU transport team. So currently, my project is and has been essentially hung up in that process, because we are in talks with CAMC and their laboratory office to carry their CLIA licensure out to the pre-hospital setting with our providers. So obviously my constraining factors are going to be my CLIA licensure, setting up the research, the startup cost just to obtain the analysis systems themselves, as well as the education for the staff. So the research that we would do as a company would start out at a single base level. CAMC actually has a spare ISTAT that they would loan to us, and we would give to one specific base that has a high patient volume. And then in order to get accurate results, there would be one patient-specific population that we would monitor. The patient population that we were discussing would be a ventilated patient that met certain criteria. We would obtain a stat ABG at bedside using the ISTAT and then tailor their vent settings to that patient specifically. The talk for the education director is that this would be a continuous process over approximately 6 months, and then we would pull the data. We would compare this data to research and the patient's ultimate outcome, and then we would decide if it would be a pertinent or feasible thing for us to bring out system-wide. The startup cost is the other major deterrent for us. These systems are extremely expensive. I actually did reach out to the 2 services that have the EPOC and the ISTAT, and they won't give me real-time numbers without a potential contract, and that's even with them contacting our education director, which isn't realistic for us until we have actually done the research to see if we're actually going to do the project. So that is a difficult number for me to provide to you, but I do know that they're extremely expensive. And then finally, the education is going to be the other big factor in this, and this is where the education director was assistive to me. So what he would do is essentially establish probably a primary education person at each base that would be considered like a super user, and that would be the contact person at each base. We would bring everybody in for an initial in-service. We have a pretty substantial system, so we would just rotate them through on a schedule, educate them about the system itself, and then send them out to their bases. And that would be our education plan. So the lessons I learned in this project is that I went into this kind of with rose-colored glasses. I say this because I went into it like with the mindset that this is what's going to be best for my patients, it's the right thing to do, and it's going to push through easily from there. I was wrong. There is so much bureaucracy and scheduling and meetings and personnel availability and management and administration that all plays into it, not necessarily on my side, but more so on the facility side, because these people are not as available as I expected them to be. So my major hang-up was time management. The other hang-up for me was the CLIA licensure. That wasn't something that I anticipated, and it wasn't something I anticipated to be so difficult to obtain. And then the other recommendation would be as far as the cost. We actually have a chief financial officer who does grant writing, and he's actually in the process of writing a couple grants for us as far as ultrasound imaging, which would be super convenient. So grant writing is something that I would recommend to make this process a little bit easier, because we could obtain funds to offset some of the cost of essentially 11 of these devices, one for each base and then a training device for the education center. For future planning, my biggest thing is just time management. Prepare for this to be an extended project. While I was able to initiate it during the class in the 3-month span allotted, I was not able to complete the project as a whole. As far as feasibility, is this something that we can fix? Absolutely. This is something that we can bring to the patients and improve their overall treatment as well as their outcome. I do absolutely stand behind this and believe that it's 100% feasible. And then I've provided references including raw data, and then where I've pulled the study material from the information I provided earlier in my slideshow. Thank you for your time.